Good morning, Harshad. Let me get you in here. Oh, you're in here already.
Good morning.
How you doing?
I'm good, John. How are you?
Good. Are you at work?
No. Today is Sunday.
Oh,
So,
okay.
yeah.
Okay.
So
That's-
after this is a Sunday afternoon, 5 o'clock in the evening.
Well, have you experienced Chat GPT?
No.
Oh man, fantastic. It makes the internet much more powerful.
Okay.
And you don't have to understand it, but you're going to see a lot of changes in the internet. It's going to be more powerful for education, I think.
Right.
So there's going to be good things happening on the internet, not just in neurosurgery, everywhere.
Okay.
You can make a video just by describing it. Can you
Okay.
imagine? Can you imagine that?
Okay.
All you have to do is you type in a description and it runs through and it's like a decent video. The same thing with an image. You can
Okay.
describe an image and
Right.
it'll make an image. Anyways, you'll see it.
Yeah. It looks like exciting. Very
Yeah,
exciting.
it will be. Okay, I'll be back.
Okay. See you.
Hello, John.
Hey, Ben, how you doing?
Hey. Fine.
I'm glad to see you got in, okay?
Yeah.
Hey, Ben,
We just finished our annual conference of Chinese Neurosurgical Association.
Oh, okay.
Yeah.
Well, Woralux is going to be a few minutes late. She's at
I
work.
know. So
Okay.
the first speaker should be the Chinese one.
Yeah, okay,
Yeah.
that would be good.
Okay.
Hey, big news, Ben.
Mhm.
Chat GPT.
Mm-hmm.
It's bringing AI to the masses.
Mm-hmm.
It's the biggest thing that happened in the internet since the iPhone.
Yeah. I know.
Yeah,
A lot of news. Yes.
Oh, well, just wait to see the changes. I think
Okay.
it's going to help what we're doing, I think. So
Yeah.
we'll see. Hey, good morning, Ahmad.
Hi, good morning.
Say hi to Dr. Ben.
Fawad.
Ahmad, unmute, Ahmad.
Hello. Good morning.
Hello.
How are
Hi.
you? Fine. Okay. How are you, Professor Bin?
Fine.
Fine.
Hi, Hashad.
Hashad, are you there?
Yeah.
Professor John Salam. Hello.
He may have stepped away. Oh, there's one lady. Okay. But Ben, now people will understand the power of AI.
Yes.
Because I had no idea it was so powerful. No idea. I mean, I heard, and they have what's called a hype cycle where they build it up, and then everyone's saying, what do you do with it? But now they can see. Now people will be able to see what it's capable of doing. Are you there, Wanley?
Hello, Professor Bean.
Hello. Hi.
Hi, how are you?
Fine. Thank you.
Fine.
No camera.
Okay. How was the conference?
I think it's very successful, and we have a live case.
Okay.
Yeah.
How many days you had this conference?
3 days.
3 days. Okay. Good. Must be very, very exciting.
Yeah. And John, please let Liu Xing. Actually, his name is in the green in the audience list.
Oh, is it attendee? Oh, okay.
His
in
name
Chinese.
is in Chinese. Yes, the green one.
I didn't recognize it.
Okay. 刘医生好，你好。
哎，老师你好。
哎，你能不能把中文名字改一下？
哦，OK。
一会儿你第一个讲啊。
哦，OK。
好的。你点住自己的那个名字，然后请右键改名，最后一个是改名。
好的。
Good morning, Dr. Zheng Liu. I'm John Bennett.
Good morning.
Yes.
Good morning. I guess
Professor Bennett.
Yeah, I guess Ben told you about the change in the order of speakers. Okay.
Okay.
And Dr. Ben will introduce you. I'll introduce Dr. Ben. We got time.
刘医生， 请袁丽介绍你吧，因为他可能
好的
跟你比较熟一点。John,
Yes.
Dr. Zhao, Yuan Li Zhao, he will introduce Liu Xing. They are colleagues in the same hospital. Yuan Li 好啊，赵主任，袁丽。赵主任好。袁丽，一会儿你先介绍一下刘姓，
OK，
好吧？
OK，
好，
OK，No problem。他是我们Pathology Department
好
Dr.
的
刘许啊。Yeah，OK。那个泰国的女医生，她是大概什么时候？她是差不多
他应该不会太久，
半个小时
他
或者
对应该是的。
那这就
他说
跟刘教授说一下，大概半小时到45分钟呗，差不多是吧 ？Dr. 刘教授。
可不敢，老师。
嗨，对，没问题。那就你辛苦，你怎么脸这么红啊？
有点紧张，红光。
No problem。
Okay, we'll start in just a minute.
Okay, John, yeah, we can
Okay.
start right now. It's 8.
Yeah, you guys are busy guys. I know that. Okay, just
No problem. We can start anytime.
okay. Here we go. Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is John Bennett from Miami Beach, beautiful Miami Beach. I have the pleasure of hosting for another in the series of the
Good morning,
China
John.
Neurosurgical, okay, I'm with it. It's like Chinese Neurosurgical Journal webcast. We've been doing this for a while. We have a few speakers today. Woralux running a little late. She's coming back from an anastomosis workshop in Bangkok. So we're going to start with Professor Zheng Liu, and Ben Zhu, the bypass king of China, is going to introduce him. Good morning from Miami, Ben.
Good
Okay.
morning. Thank you,
Morning.
John.
Oh, okay.
Thanks.
Morning, yeah. Okay. This is usually this Chinese Neurosurgical Journal webinar will be hosted by Dr. Bing Xu from Shanghai Huashan Hospital and myself.
Hello.
I'm from Beijing Tiantan Hospital. And today we have two speakers. One from Beijing Neurosurgical Institute is the pathologist, Dr. Liu Xing, and he will talk about the diffuse, the adult type diffuse glioma, the pathology and treatment. And after Dr. Liu's speaker, Professor Xu will introduce another speaker from Thailand, a lady neurosurgeon, talk about the art of neurosurgery. So at first, please, let's invite Professor Liu Xing from Beijing Neurosurgical Institute to give his talk. Please, Professor Liu.
Okay. Dear everyone, good morning. It's a great honor for me to have this opportunity to participate in this online seminar of the Chinese Neurosurgical Journal. I'm very grateful to Professor Zhao and Editor Louis for their invitation. I am from the Department of Neuropathology, the Neuropathology Center, Beijing Neurosurgical Institute, and Beijing Tiantan Hospital. The topic I'm discussing today is about the diagnostic practice of adult diffuse gliomas. Okay, as we know that the development of neuropathology depends on the development of technology. Initially, we look at the tumor in general for shape, color, and their relationship of the tumor to the surrounding tissues. Later, we can use HE staining and observe their tumor morphology and some structures under the microscope. And then we can use methods such as immunohistochemistry and some special staining methods to observe the origin of tumors, the proliferative index of the tumors, and some markers that are related to the specific genetic alteration. And then we have some methods such as the Sanger sequence and FISH. Use these methods, we can evaluate the genetic landscape of a tumor. And now we have some techniques such as next generation based target panel or the DNA methylation based methods. With these methods, we can detect, understand the central nervous system tumor deeper and deeper. This is the 2007 edition of WHO guidelines for the classification of central nervous system tumor. And I think it might be the most familiar version of the guidelines for most of the neurosurgeons and neuropathologists, because this edition provides a very detailed description of morphology, and all tumor diagnoses are still based on the histological presentations. And then in 2016, the first revised guideline introduced the indicators of molecular pathology for the first time, combining the histological features and molecular pathology indicators to form an integrated diagnosis. From then on, our diagnosis of the central nervous system tumor depends not only on the histopathology, but also on its molecular characteristics. Okay, this is the 5th edition of the WHO guideline for the CNS tumor. It has made great changes on the basis of the previous edition. It established a series of new types and several new types of tumor, and it also redefines the grading system of the central nervous system, and it further emphasizes the importance of molecular testing for the diagnosis of CNS tumor. So now the WHO CNS5 divided the glioma, glioneuronal tumor, and neuronal tumors into 6 groups. The first is the adult type diffuse gliomas. The second and the third is the pediatric type glioma, which can be further divided into low grade and high grade. The first one is the circumscribed astrocytic gliomas. The fifth is glioneuronal and neuronal tumors, and the last one is ependymal tumors. Okay, the 5th edition recognized that the clinical procedure and the molecular alteration is different between the adult type diffuse glioma and the pediatric type glioma. For example, in the adult type glioma, we should detect the IDH1 mutation, but in the pediatric type, the most frequent alteration is H3. The histone H3 alteration or the MAP kinase signaling pathway alteration. So in this edition of WHO guideline, we have divided the glioma into adult type and pediatric type. But we must make sure that we must note that the the pediatric type or the adult type here is not the definition of the adult type and the pediatric type is not only depend on the age of the patients, but most depend on the molecular alterations between these tumors. That is to say, some adult type glioma can be diagnosed in the children, and some pediatric type tumor can occur in adults. Okay, let's take a look at the key points of diagnosis for each tumor in detail. The first one is astrocytoma IDH mutant. The definition of this tumor is diffuse infiltrating IDH1 or IDH2 mutant glioma with frequent ATRX mutation and or TP53 mutation and the absence of 1p19q deletion. And from the definition, we can say to diagnose this tumor, we have 3. The first one, we must to make sure 3. The first one is it's a diffuse infiltrating glioma. The second one is it's IDH1 or IDH2 mutant. The third is it always show the ATRX mutation or TP53 mutation and absence of 1p90QQ deletion. This tumor can be divided into 3 grades: WHO grade 2, WHO grade 3, and WHO grade 4. This tumor can be located in any region of the CNS, including the brainstem and the spinal cord. But the most commonly developed in the front lobe. The location is similar to that of LH mutant and 1p90QQ deleted oligodendroglioma. Okay, let's see the histopathology of this tumor. The CNS-WHO grade 2 tumor are composed of glial cells that diffusely infiltrated to the CNS matrix and generating a loosely structure and some microcyst matrix. The cellularity is mild to moderately increased compared to that of normal children, and the nuclear atypia is the mild nuclear atypia is characteristics. Tumor cell density and the cellular morphage may vary, and some histological features are very difficult to recognize and compared to the normal brain cells. The CNS-WHO grade 3 tumor, the distinguish from the CNS-WHO grade 3 astrocytoma from CNS-WHO grade 2 astrocytoma is the increased mitotic activity. We can see in this picture, this is a mitosis, and the histological anaplasia, such as the increased density of the tumor, and sometimes we can also say the very crowded tumor cells and with some mitosis. But in present edition, the threshold for CNS-WHO grade 3 destination has not been established. So the diagnosis of grade 3 or grade 2 astrocytoma LH mutant is subjective. Okay, this is a CNS-WHO grade 4 tumor. We can say from the picture, it shows the MVP, microvessel proliferation, and sometimes has the necrosis. The histological feature of this tumor is very similar with the glioblastoma LH wild type, but some detailed features may be different, such as the necrosis may be more often in LH wild type glioblastoma, but the distinguish from these two tumors is mainly dependent on the detection of IDH mutation. Okay, this table is about the grading of LH mutant astrocytoma. We can see from this table, the CNS-WHO grade 2 and CNS-WHO grade 3 tumor astrocytoma. These two tumors was infiltrative astrocytic glioma. Grade 2, the mitotic activity is not detected or very low, but these two tumors don't have the microvascular proliferation, necrosis, or CDKN2A2B homozygous deletion. Okay, the immunohistochemistry index for this tumor is GFAP, olig-2, vimentin, IDH1, R132H mutation antibody and the ATRX or P53. This tumor, because the tumor are astrocytic tumor, so the GFAP and olig-2 are positive, and the vimentin is positive. The pattern of vimentin was very similar with GFAP. The LH1 R132H antibody is positive, which show it's the tumor is LH1 mutant, and the ATRX staining is loss. The P53 is positive, usually larger than 10%, diffuse positive. Okay. After we evaluated the histological presentation, the IHC staining, we have to do some molecular test. The most common, the most typical molecular feature of this tumor is the ATRX loss and the loss or mutation and the TP53 mutation. And besides this diagnostic indicator, we also have some molecular features which are associated with the progression of this tumor, such as the CDKN2AB deletion, CDK4 amplification, such as the MET alteration, RB1 deletion, PIK3CA, PIK3R1 mutation, PTGFRA amplification, and Wesson amplification. The tumor with these alterations may not be diagnostic as seen as WHO grade 4 tumor, but this tumor may show a worse prognosis. So if we did this molecular test, we must report it in our diagnosis. Okay. The second type of adult type glioma is the oligodendroglioma, IDH mutant, and YP19Q deleted. This tumor is a diffusely infiltrating glioma with LH1 or LH2 mutation and the co-deletion of chromosome R1P and 19Q. From the definition, we can say this tumor must have a LH1 or LH2 mutation. The second is the whole arm co-deletion of 1P19Q. This tumor can be divided into two grades, the WHO grade 2 oligodendroglioma, the WHO grade 3 oligodendroglioma. It can also located throughout the CNS. But according to the CBTRUS statistics, about 59% were located in frontal lobe, and 40 are located in the temporal lobe. Okay, let's see the histopathology feature of this tumor. We can say the classic oligodendroglioma cells have uniform and round nuclei that are slightly larger than those of normal brain. A distinct nuclear membrane is often apparent. In the formalin fixed paraffin embedded tissue, tumor cells often appears as a round cell with well-defined cell membrane and a clear cytoplasm around the central nucleus. So this feature is called the fried egg appearance. So this appearance is the typical presentation of oligodendroglioma. The second very atypical feature is the blood vessel. Oligodendroglioma typically show a dense network of capillary branching capillaries. So we can say the CD34 staining of the vessel showed a very dense vascular network. And in some cases, this, especially in the WHO grade 4 to grade 3 tumor, we also can say the molecular vascular proliferation. The grading of this tumor mainly depends on the mitotic activity. A tumor showed larger than 6 mitosis under 10 high power field can be diagnosed as the WHO grade 3. And if a tumor showed the MVP or necrosis, especially some tumor showed the silicon 2A2B deletion, we can diagnose this tumor as a WHO grade 3 tumor. The immunohistochemistry index for this tumor is also the GFAP olig-2, which show it's from the neuroepithelial cell. And the next one is the IDH1 R132H, which may show it has a IDH1 mutation. From previously research, we also use the IDH2 R172K antibody to recognize the IDH2 mutation. We can see from this picture, if a tumor have a positive staining of this antibody, we found that it's very consistent with the NGS results. So if we use this antibody to recognize the IDH2 R172K mutant oligodendroglioma. This tumor always this tumor is HRX positive, and sometimes it's always P53 wild type, but sometimes, especially in the high-grade oligodendroglioma, we can see a positive staining of P53, but the NGS results always show the P53 is wild type. So the use of P53 to evaluate the mutational status of P53, TP53, is not very consistent in oligodendroglioma and astrocytoma. The H3K27 trimethylation is always reduced. So we use this antibody, H3K27 trimethylation antibody could be used as an indicator to distinguish from astrocytoma and the oligodendroglioma. Recent articles also demonstrate that the use of vimentin is a very useful marker to distinguish oligodendroglioma and astrocytoma. Vimentin is negative in oligodendroglioma and positive in astrocytoma. So if we don't have the NGS methods, use vimentin, H3K27 trimethylation, IDH1 mutation antibody, ATRX antibody, we could effectively diagnose to distinguish astrocytoma and oligodendroglioma. Okay, the genetic landscape or the molecular pathology of oligodendroglioma is IDH1 mutation. Larger than 90% is R132H in this codon. And the IDH2 mutation is more common than astrocytoma IDH mutant. So according to our statistics, about 6 to 7% of oligodendroglioma was IDH2 mutant, and about 77 were IDH2 R172K mutant. So that's why we use this antibody in the clinical practice. This tumor always showed the third promoter mutation, about 90%, and the SIK mutation about 70%, and 20 to 30% of FUBP1 mutation, and about 15 Notch1 mutation. Okay, some markers or some molecular alterations also associated with the progression of this tumor, such as the CDKN2A2B deletion, PRK3CA mutation, TCF12 mutation, and MYC activation. A previous article demonstrated that the polysome of 1P90Q is associated with the poor outcome of this tumor. So if you could detect this feature, we should report them. Okay, here is a case. This patient is a 67-year-old male. The histological diagnosis is oligodendroglioma, WHO grade 3. The molecular test of this tumor showed that the 1P90Q is co-deleted, and the IDH1 is wild type. IDH2 is wild type. The MGMT promoter is unmethylated, and the third promoter, C228T to C250T, is wild type. So it's very confused that this is a IDH wild type tumor and showed the 1P90Q co-deletion. So we're trying to explore whether this is a true oligodendroglioma or some other identity. We noted that we use the fish to detect 1P90Q. So we subject the tumor tissue to DNA methylation test. And the DNA methylation test showed that this tumor should be classified in the MC family of glioblastoma IDH wild type. So that is to say, if we use the fish method to detect 1P90Q, we must be very variant that the design of the fish probe is limited. So the fish can detect 1P90Q very sensitively, but the results, the design of the probe is too short. It often can't represent the entire arm, the whole arm. So sometimes it will present a false positive results. Okay, the next one is the glioblastoma IDH wild type. The definition of GBM IDH wild type is a diffuse astrocytic glioma that is IDH wild type and H3 wild type. So from this definition, we can say, if we want to diagnose GBM, we have to make sure that the tumor is IDH wild type as well as H3 wild type. And the tumor must have one or more of the following histological or genetic features, such as microvascular proliferation, necrosis, third promoter mutation, EGFR gene amplification, and chromosome 7 and 10 copy number changes. This tumor is seen as WHO grade 4. Okay, from the HE staining, we can say it's a diffuse and infiltrating and with highly cellular glioma. Usually the tumor is polydifferentiated, and the tumor cells showed tumor atypia and often marked pleomorphism. Mitotic activity is very brisk, is often brisk, and the microvascular proliferation and necrosis always presented. This tumor has 3 subtypes. The first one is the giant glioblastoma. We can see some very giant cells in this tumor, and this tumor always with a high frequency of P53 mutation and the mismatch repair genes deficiency. The second subtype of GBM NH wild type is gliosarcoma. This tumor often showed a mixed lesion with conventional astrocytic phenotype and mesenchymal differentiation. The third subtype of GBM NH wild type is epithelioid glioblastoma. This tumor is always showed composed of a predominant population of relative uniform epithelioid cells with the round cell border and some eccentrically placed nuclear. This tumor is enriched for BRAF V600E mutation. To diagnose the GBM NH wild type, the useful HC marker is GFAP olig-2 EMA LH1 R132H antibody, the HRX P53 KS67 CK, such as these markers. So it's always GFAP and olig-2 positive. If a tumor showed olig-2 negative, we must make sure that this tumor is not H3G34 mutant. Okay, the molecular pathology of the tumor is LH1 and LH2 wild type, as well as H3, histone H3 wild type. That the H3 wild type is to exclude the H3K27 altered diffused midline glioma and the H3 G34 mutant glioma, the pediatric high-grade glioma. And this tumor always show the EGFR amplification and TERT promoter mutation, and the gain of chromosome 7 and the loss of chromosome 10. Okay, here is a case. This is a 62 male. The histological diagnosis of this tumor is astrocytoma, WHO grade 2. But the NGS showed that is IDH1 and IDH2 wild type. I'm sorry, it's also a H3 wild type tumor, but this tumor showed TERT promoter mutation and the amplification of chromosome 7 and the loss of chromosome 10. So this tumor, although this tumor is astrocytic glioma with low Ki67 index, and we didn't say the microvascular proliferation or the necrosis, even didn't have the anaplastic feature, but this tumor have to diagnosed as a GBM NH wild type according to the WHO CNS5 guidelines. And these patients this tumor recurrent after about 10 months after the first surgery. Okay, above is the adult type glioma. Even though although we have made so I'm so sorry. Above is diagnosis of the adult type diffuse glioma. We have made great development in the integrated diagnosis, but some technique may also aid in the diagnosis of CNS tumor, such as the oncogenic fusion of the tumor. As we know that with the development of RNA-based next generation sequence, we have found a lot of new fusion gene in the central nervous system. And this fusion gene, especially some oncogenic fusion and some of these oncogenic fusion may promote the progression of the CNS tumor. So maybe in the future we have to detect the fusion as well. And this is the clinical protein test landscape of the glioma and the pediatric tumor, high-grade tumor. So maybe in the future, with the help of the proteomics, we can have more indicator, more biomarker for diagnosis, as well as some biomarkers for the prognosis evaluation. Okay, that's all we for my topic today. Thank you very much.
Thank you. Wan Li. Hello, Wan Li. Are you there? Okay, or Ben? Okay, well, I guess thank you very much. Yeah, you want to take over, Ben?
Yeah, I see Takashi.
Yeah.
Do you have any questions?
Yeah, thank you. I'm Dr. Takashi Kon from Tokyo, Japan. And thank you for the nice lecture and nice reviewing. The WHO 2021 is very complicated, but genetical, complicated genetical diagnosis. So your review is very, I understand freely. So smoothly 2021. And as for the GBM diagnosis, not only P53 or other molecules, BRAF, V600E, and TERT promoter mutation also important. So this was a good review. A good opportunity to review the 2021. Do you have any experience of diffuse midline glioma A3K27 mutation? Do you have any experience? And this will contribute to the poor prognosis.
Okay. In our department, we have several cases about 100 to 200 patients with H3K27 altered. Most of them are H3.3 mutation, and only two or three of them are H3.1 mutation.
Oh, okay.
And about 17 of them are H3 wild type, but EZHIP overexpression, and about 2 to 5 patients harbored the EGFR exon 20 insertion. So the diagnosis, as you say, the diagnosis is very complicated, because some tumor didn't located in the midline of the central nervous system, such as the frontal lobe, but also show the H3K27 mutant. So we have to diagnose the tumor as a high-grade glioma with H3K27 mutation, NEC. So maybe because in the previous article, we can see that the origin data showed the tumor located in the front lobe with H3K27 mutation, also centered in the H3K27 altered methylation cluster. So maybe the location of the tumor is not the diagnostic criteria for this tumor, but the molecular mutation is molecular alteration is more important.
Yes. Thank you. Thank you. Yeah, I learned a lot. Thank you very much.
Dr. Liu Xing, so most of the diagnosed molecular analysis is post-operative. So is this any like this post-operative molecular diagnosis affected the treatment strategy after the surgery?
After the
because
surgery.
yes, because if you notice that some more not so sensitive to the chemotherapy or some kind of other radio surgery, maybe you can resect it more extensively, maybe in the second stage.
I recently read some articles about the molecular test during operation, such as a team from Qilu Hospital, and they use IVD product to detect the LH and the TERT to make sure to distinguish the tumor between oligodendroglioma and astrocytoma LH mutant. And I know Professor Mo Ying from Huashan Hospital have also used the MS methods to detect LH mutation. As my mentor, Professor Jiang Tao, they have an article demonstrated that if a tumor was oligodendroglioma, LH mutant, and 1p92 deletion, which located in the motor area, we can resect less to protect the function of the patients. But after the operation, we can use the chemotherapy or radiotherapy to make sure they can survive longer, or as long as the GTR patients. So the molecular test during surgery, during the operation is very important. Is very hated topic in the research field. But as we know that the MS or some IVD product have to under carefully evaluation before they applied in the clinical practice. But now we have some IHC rapid immunohistochemical staining methods to make sure to test this tumor, whether this tumor is LH mutant or wild type. So that is a very good question, and our neuropathologists have to make more efforts in the future.
Okay, now how fast it can
about 10 to 20 minutes.
Okay, that's quite fast. Yeah. Okay. Thank you very much.
Thank you.
Okay, any more questions or comments from the panelists? Okay, thank you very much, Dr. Liu, and we hope to see you in the future. Before I turn it over to Ben for him to give a proper neurosurgical introduction, I'd like to say hi to Woralux. I really appreciate her coming by. She just recently finished an anastomosis workshop in Bangkok. She's worked for our Neurosurgical TV doing graphics for Yuha. Yuha did this webcast for a couple of years, and she did a lot of graphics. So I'd like to welcome Woralux. Good day, and thank you for running from the airport to the hotel.
Yeah.
Hi.
Now let's welcome Dr. Woralux. Now I think we should congratulate her that now he is the head of the neurosurgical unit I think it's in a very beautiful city, Chiang Mai.
Yeah.
It's a very beautiful city that just
Yes.
like Miami in Florida.
Oh, okay. Nice.
Okay, now the time is yours.
Okay.
Woralux, you can share your screen.
Yeah.
Yeah. Mhm.
Okay, hold on.
Okay. Temporary lapse in memory. Oh, Woralux, did you fall off? I think we may have lost her. Just be patient. Yeah. Sometimes you push the wrong button when you're doing the presentation, so we'll just be back in a second. So that's a common thing, anastomosis workshops been amongst young neurosurgeons.
Yes.
It's a common thing, and pretty regular, the residents do.
Yes.
Okay. Mhm. She should be coming back shortly. Oh, she's back. Okay, great. Great. Oh. Good idea.
Okay, sorry. So sorry, guys. So
Welcome
can you hear
back.
me now?
Yes.
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 Sorry. I just back from the workshop, but it's okay. So first of all, I would like to thank you to the China Neurosurgical Webcast to give me these opportunities to present in the kind of like news ideas, maybe some like, let's say it's like light talks today after the brain tumor classifications for the new guideline, in which I also agree that it's kind of like confused, but it's kind of like we need to study with the knowledge that keep updating each day. Okay, so today I'm going to talk about what I am doing. So today my topic is about the use of arts in neurosurgery. So
Do you want to screen share the Woralux? You're not screen sharing.
oh, I do the screen share already though.
No, try it again.
Okay. Okay, can you see?
Yes, that's better.
Okay, sorry.
And you want to do presentation mode? There you go. Perfect.
Okay, that's perfect. So this is the use of arts in neurosurgery by me. And as of course that I still a neurovascular surgeon and I work every day. So now it's like I hope this topic going to be useful for the medical students to encourage them, or they can use it for like apply their daily work or studies to their like studying every day. And so I just applies for the everyday works into an art, in which nowadays it turns to my another hobbies, and maybe it's also turned to my second jobs. So so I would like to officially tell who am I. So my name is Dr. Woralux Phusoongern, I am neurovascular surgeon, that's my specialties, and a neurointerventionist. And I also the medical illustrators. My work is quite unique. So I did not like do just a simple art and just send it to the websites to sell, but my work is just like I would like to create something is new, especially for the new, like, articles or the textbook. And I just going to talk to the authors or the writers, and then I just create it as they decide. I started working as a medical illustrator in 2019 until present. But as now it's kind of like, I kind of get a busy work, so it's less work, but I'm still like working on it. So as I told you earlier, is that my work is quite like unique, but it's not unique because of me, but it's also like by the specific type of works as the authors or the writers or the publishers ask me to decide for them too. If you want to see, like, how's my work art or my art is like, so you can access me through the social medias, Facebook, Instagram, LinkedIn, Twitters, or the website itself. So I have plenty of the previous artwork and the recently works that I might currently work on there. So yeah, so if you want to so I have, today it will be like the art show or something, so you can just like, sit there and just enjoy seeing the art, and maybe you can like scan that QR code and see, like, some of my stuff. So I am not a professional artist, or I did not go to the art school before. I just like, just typical girls and just study in the med school. And I just start sketching on the simple like papers and the pencils, that's all, in the anatomy class. There's nothing much better than just to help you to memorize things by just take a note and start sketching. You do not have to be scared that maybe your art is not as pretty or your art is not as beautiful. You just to make sure that you just you have the contents or something that you should have to remember. That's the point. And then when I get into the neurosurgical residence, I also use that things to help me to memorize and to study and to assist it into the short note, operative notes. And now then I turn to the digital illustrations, and then I try to adapt it to the more like surgical procedures or apply it to. My work is not only related to the neurosurgical fields, it's also spread to the plastic, neurosurgery, general surgeries, of orthopedics, or even the traditional medicine itself. So it's not limited. But the basics, like, for my artist studying at the anatomy class, this is some of my artwork since I was in a medical school, that like, you can just use only the simple paints and just scratch down in the papers and just take note. And then I just like, since I just read on only my short note, and then you will remember like exactly what you write on, and you just like, close your eye and you just use as knowledge into your brain from your memorize, and you just like, use that in your exams or when a teacher asks you. And sometimes if I have more time, maybe you just like, can use this to help you to relax in your free times, so that you do not have to be stressed out too much when in the medical school. So this helped me a lot. And if you just start to be scared that, okay, maybe to start an art, maybe you need a lot of things to work on. Maybe you have to buy a new color papers or the very perfect, like, pens or pencils for sketching. No, just your pen, just the pencils and the simple paper, it also can create artwork. And for me, I think art is like a surgical skills too. From the first day and until now, it's kind of like, time. It's like learning curve. of course that maybe if you compare your arts on the first that you start sketching and from maybe take a years, you can see the total difference. So this is from the short note from my the anatomy class, in which like we have to remember all everything. And as you see that, you know, they have a lot of like letters and many different colors. So it can count that out of how many times that I like, you know, remember or read it. I also do some other stuff, maybe like, you know, make it more like beautiful and help me to relax in the class where I study. As you see that like only the black pens and some sketch, like, you know, things. And then when I studied in medical, when I training at the neurosurgical residence, so of course that after that you finish the operations, you have to write down the operative note. Maybe sometimes, and as an English is not my primary language, so for once that you know you want to write something down, maybe you have to think about the grammar, think about the vocabulary. So for me, I just like, you know, tries to draw it first. What the important findings that are first thing, and another thing is important is about the patient positions, incisions. So, and when you keep doing that, some of the operations, it will be repeatedly almost the same, and it can help you to remember. And it actually can help me nowadays that it can help you to remember the operations like steps more precisely. And one of the operative note that I like to draw is the aneurysms clipping at that times. So I will start since from the patient's positions, but most of the cases Turian, maybe only one of the operative note that I will draw only for the how to adjust the patient's positions, and then what is the skin incisions should be, so understand how to open the scalps, skins, and then open the dura, because maybe many of the surgeons have a different type of style, and especially for the positions or the locations when or to place the retractors, and then the finding insides. And it actually can help because once that you know when you retract the frontal lobe or the temporal lobe, you will remember, like, you know, what is the first anatomy that you should see, and the relationship between the optic nerves and the ICA. Especially for the, like, you know, neurosurgical resident who attend the aneurysms clipping, you know, because maybe sometimes when you read another person operative note or the textbook, maybe sometimes the positions of the anatomy is flipped because it changed the size of the approach. So if you keep doing that, so it can help you to memorize. It's much better than just maybe just only look at that, because maybe you might like forget. And another things that that I do is the way that how you hold the instrument, because for me at the beginning, I am left-hand sided person. So there's not in my countries, there's not that does not have the instrument that serve and suit for the people who have the left hand side. So of course, at the beginnings of my trainings, I have to use a lot of abilities to adjust about that a lot. So I have to, like, you know, I mean, tries to practice that many times and make it like perfect. And I have to practice to write and to operate it by two hands. So for drawing itself, it can help me to with those skills too. And as you see that at the beginning, I tries to draw almost always for my operative notes, and then I realized that, you know, sometimes it's almost always the same, and then it's can help you to remember, and you just recorrect it what you're drawing is correct or not by you checking in the textbooks again. Of course, that you do not have to worry. It's going to be beautiful at the first place, but remember the important part is the important thing, just like, okay, what is the patient position should be, what is the scalp flap should be, the positions of the first blowhole and the number, and the dura, incisions. And then you just like add the text after, and yeah. And for the spy, for the like important finding is also like important details. This is craniopharyngioma. I remember this draft I draft when I go and observe my another mentors while he operating. The interesting things is why I want to drafting on this, because the way that he put his retractors and the way that he hold the instruments, and this craniopharyngioma is adamantinomatous. So of course the flank thing is a calcification. So it helps me to remember. And after that, when I got my iPad, so I start to draw it on the iPad instead. So this is the I think it's very first piece of my operative note that I actually draw on the iPad. And the reasons why I had to draw it, because I think this case is very interesting. We have to do the total welt corrections in the cranial synostosis, and I am the chief resident at that time, and I have to present that to the surgeons conference, and I just afraid that maybe only the word itself, maybe they do not understand what we're doing. So that's why I think that maybe to draw it can help them to understand much better. And second thing is this type of operation, it's not happened as often, and I am the chief resident, so that's why I do not have time to go out and just like start to taking a picture. So my challenge thing at that time is I have to try to remember all the steps, and then once that I finish, I just have to take my memories and like try to draw it step by step, the very important one, and then it's give the the very good results. And then I did not know how to describe the procedures in the very simple ways for other people to understand. So I just tries to describe from the picture that I draw to be the procedures that I wrote in my operative note. And sometimes it's so, and after that, so I just like tries to draw my operative field that I do. And this case I draw it because how interesting that I tries to adjust the way that for the cell retractors to hold and to can make the incisions like wider. And this case is an example again that we have to present the procedure to the other surgeons. Maybe they might not understand if we just like explain to them in the word or something. So I have to draw and then I have to explain to them. So why I do prefer, because I think it's for me it's faster and it's give the more clearer message, and it can help me to stimulate my imaginations and creativities, and especially for the help me to memorize things more, because once that you keep doing that more often, and you will memorize it much better. So how do I find the drawing is used for my trainings, and I think it's very helpful for the younger generations who is do not have to be neurosurgical trainings, but maybe for the medical school who's still studying, or the surgeons in every field. So it can help you to do the surgical plannings. And maybe for the surgeon as us itself, maybe if you can planning ahead what it should find in the operation. So you can have plan A, plan B. So it's helped me to plan for the P and post-operative. And it can help to memorize the procedural, because maybe some procedural that you did not do that often. And sometimes it can help you to choose the proper instrument while you do the surgeries. And the important thing is it can relax and fun. So, okay, for this one, maybe I will tell you that what the program that I use. This one is GoodNote. I'm not sure that it's still free, but at that time that I use that is still free. The benefits for this application is I also use that as the short note tool, and it's also can like do the simple drafting of the pictures too. So you can have like, you know, make it like a very beautiful operative note, and you can print it out and with the colors too. This one I think is free. It's a Sketch Pro for whoever like to draw, but like but the style is kind of like, you know, like the pencil style or drafting. So maybe this applications is good for that, and it's also can make a very unique beautiful colors. This one is from the Sketch Pro. I usually do it like, you know, when I was asked to explain it to my junior residents, like brief case that what is should be the step 1, step 2, step 3, and since beginning. So this one is like very simple and no need for many techniques that use in the apps. And this is another app. I think it's still free, and many artists or many neurosurgeons whom I know, it's still free. So that's why this is the one that I always recommend for my friends who want to start doing that. This one is also good. This one I draw it from in the skull-based conference in Bangkok when Professor Ive Chiran, he gave lectures on how to do the skull-based dissections. I just observed it on the TV and just like I think that if I keep like, you know, watching, maybe I might not like remember it all. So I just like only drawing for the important part. But nowadays I use this one. It's called Procreate 5X. The good part is you just can only buy it one time, lifetime. You do not have to buy it like, you know, monthly. But it does not create the vector picture. So if you just have to create it to and apply it to some other things. Maybe you want to screen it on the t-shirts, or you want to use it for the more illustrated program. Maybe you have to adjust that to some other program because it's not create a vector picture. But another thing that is I like about this program is I can do the animations assist with these programs too. So another thing that I think that to drawing is very helpful for my work is prepare for the test. So I just create that these two illustration, and actually these are the animation. So I just create that for me, actually simply for me to remember for example, this one is the relations of the skull marking to cerebral anatomy. It's very important for the neurosurgeons to remember at the time that if you do not have neural navigations. So you have to remember what is the important surgical anatomies. So for drawing itself, it can help me to remember a lot, and the flow of the fourth ventricle, in which they have a lot of important structures. So by using the application that I suggest you can create it is fine. And you just can save it in your like phone, and then you can just like remember it's anytime, maybe before you go to bed. So it's very simple and fast. as I told you that you do not have to worry that, oh, you do not, an artist itself, you do not have the art skill. For me, I just compare to you that at the beginning of my drawing, it's like a surgical skill. It will improve by times. Like if you keep practice every day, you can try if you like operate like, you know, 1 case per day, and you just tries to draw in every case of your the case that you do. Maybe you can compare from the 1st January on for the 31st like December. It's going to be much different, and in which in a good way, like a lot of progressions. Okay, so this is I'm talking about the use of the art in the surgical planning. So this case, she had a ruptured aneurysm in which in the CTA. So the teacher asked me before we go into the OR that what should be the proper approach, and in that approach that I should, what it should be the surgical finding. And as you see that actually in real life, I do not pay attention that it have to be much beautiful and perfect angle of the shadow in which I want to shade. So you just simply do the very important thing, just like what it should be the cranial process, what should be the optic nerve, what should be the ICA, aneurysms, PCOM, oculomotor nerve, and the basilas. And then maybe sometimes that you can make it like an exercise that you can draw it and challenge yourself before you go into the OR, and then you just see. So in the operative, it's like the answer for you, and you just finish the case and you just draw it again, and you just compare to the previous pictures that you draw. And if it's not correct, do not give up yet. So you just have to keep doing that until it's every time it's correct, and you will amazed by the results that you will improve by, you can improve by both skills, like drawing skill and surgical skill as well. So yeah, at the beginning for the operative, no, you don't have to worry again. So maybe start with the rough drawing of the pens, and then you can color that after or shadowing after. Or sometimes that maybe some of you do not know, like, you know, how to start. Maybe for me, I just study from backward. Maybe you just take a video from the microscope, and it's the good way that you just study step by step, and you just drawing from the video. And then I do it only in the, like, you know, in more difficult aneurysms clipping case. Like this case is the right PCOM aneurysms, and my teacher approached it by the anterior temporal approach. So I just draw it, and I want to know, like, what is the, if on the anterior temporal approach, what is the operative, how is the operative field will look like, or difference from the simple Therians, and the relationships between the aneurysms, oculomotor nerves, and some of the important structures. Or maybe some of the picture that you just want to picture and keep it as your memory. So this one I draw it all of that, because this is when I go and training. Sometimes that to be a surgeon itself is not only for the surgical finding it's important, but it's everything. Even your sitting positions, your back, you should not, like, you know, I mean, if you have not a good posture, maybe it will make you have a headache or neck ache after that. And second thing is maybe you do not have the confidence to do the surgery. So sometimes it's better that to remember, like, you know, what is the appropriate positions. And other thing is about the working length of the microscope and the proper place of the instrument is also important too. So it's like in the detail. Some other thing is maybe you can use that as to help you to memorize or remind yourself of the post-surgical procedure. So this one is I just demonstrate the step to doing the suction decompression technique of the clipping aneurysms that we have to do the incisions and the necks and the brain at the same time. So this is the art work of the anatomy, surgical anatomy findings that I do is before 2019 or 2018. So most of times I would do like operative finding, and if you do that often, it will be exactly the same, and you will remember like how it looked like or what it should be the clip that you should use to clip an aneurysm. This one is I was asked to draw the operative finding before I go into do the tumor resections by only watching the MRI, and my teacher told me to use an approach and what it should be the surgical finding. And this one is the OC approach for the superior lateral approach for the orbital like tumor. So yes, of course, my tools is only the MRIs, and I just have to guess and to draw the surgical finding. So as you see that right after that, I keep practicing for a while, and then at that time I do not have an obstacle or scare whoever gonna judge my art, but at the time go by, it's like the surgical skill, my art skill and surgical skill is improved. So both things like, you know, make progressions. So I'm not only use art only for the anatomy itself, but also for the very interesting surgical finding, what you're gonna see and how the instrument should be placed like. It's very important. Okay. Yeah. So this is other work that I do. So one of the things that I like, so people say that one might begin with philosophy but would end with medicines, or start with medicines and find oneself in philosophy. But for me, that one might begin with medicines but would end with arts, or start with arts and find oneself in medicines. But for me, I would not end with anything. So art and medicines are the same. So I think my conclusion for the use of art in medical education is helping in the learning process, and for traditional arts and for the new technologies, it can help in the teaching and discussing process, and for communications and discussion. So this is my website that I post about my previous work that I used to do. I mean, right after that, I finished my trainings, and I just I've drawn a lot when I was training for the important finding, and for the help me to study in the anatomy why I do. So my working experience now, it's gonna be 8 book illustrations that I have done so far. Thank you for the opportunities that they give to me. It's really amazing. So these are the number of the book that I use to illustrate. This is my recently one, not recently, but okay, recent one. So I illustrate this. I have to say that I design these illustrations for the neuro interventions teachers whom I really respect, and the challenge thing is for the original of the picture is really 2D, but when I driving to her at the beginning, she told me she wants some things that have to be look like the real like venous sinus. So that's why it's I make it this one. This is the original draft. This is the first book that I illustrate, so it's kind of like very cartoon. Also the surface anatomies, and I also do for the vascular anatomies too. So I think that for the, because my specialty is vascular already, so it's not different, and it's kind of, you know, interesting for me, so that I can learn from some other fields too. And this one is a Thai massage acupuncture poise. So this can help me to remember all the anatomies again. And not only the textbook, I just like really happy to work with the very amazing authors and the writer all over the world, that maybe sometimes it just takes me and it just tell me the idea about the new things that they're going to write about or create about. So just like, for example, this thing that I illustrate from the progress in neurosurgery contribute for women neurosurgeon in Asia and Australasia. So this one, I call it surgical for the woman neurosurgeon, and this one is called window to neurosurgery. The meaning behind this one is in every findings have a different window, and in each window it should be the proper, like, you know, approach to that findings too. This one I was asked to do it by the orthopedic surgeons, who he want me to design some of the illustrations that can help people to understand the procedure about endoscopic access in the C2 Y insertions. This for the surface anatomy of the transverse sinus. Not only the surgical anatomy, but for the everything's about the surgery, I just do. This is from my recent textbook. This was a cranioplasty that I using the titanium edge. Is very beautiful, so I just want to memorize that. For the peripheral nerve, and this one is for the how to approach in the anterior rhinoscopy for the ENT doctors. And also for the new technologies for the instrument or the new instruments. And for this one, I tries to make a textbook that talk about the operative note, but like in the more interesting style. And this one is from my recent work that from the infratemporal endoscopic assist surgery. I think you will see it in the upcoming. They still in process of that. This one is a spinal anatomy textbook that I'm working on it. Sometimes it's I would do it like the illustration set from the operations that I do. Actually, like, you know, this illustration set is not like far away from me. It's just like, you know, the operations that I do every day. This one, I draw it from the article that talking about what should be the procedures to take this hooked out in the penetrating injury. This one is for the anatomy of the orbital tumors. This one is for STA and MCA by parts textbook that I illustrate for screen for Dr. Ive and for illustrations. Can do drafting maybe for surgical anatomies too. So actually, most of my artwork I will post it on the Instagram, but you can also see it in the link in too. But if you interesting, or actually for if you have any idea or some things, I always open and I always excited to like design some new things or chat or some new things. It's always challenge for me. I also the Asian editorial boards of the Asian Journal of Arts and Culture for the International Editorial Board. And I used to do the art exhibitions, and I work, actually I also illustrate for the entire of the Royal College of Thai surgeons. So it's difficult for me that I to draw some other things like under the that not the CNS and PNS, but it's also a challenge for me. Almost finished. So actually I planning to open the like maybe online and on-site workshop for whoever wants to draw. As I told you that you do not have to afraid that you're not an artist. I am not an artist myself too. But for these type of things, like you can improve it by time. It's like learning curve too. So this is an art class that I was asking to do for the neurosurgical training. So at last, I would like to thank Dr. Beans to give me these opportunities. Thank you to Johns for giving me these opportunities. And I hope you guys enjoy this. It's kind of like, you know, different topics for you, but I hope it's useful, like not only for the neurosurgeons, but for the medical students or whoever like interested in art. And for me, I think that as neurosurgeons, we can do everything. Yeah, thank you very much.
Thank you. Thank you, Woralux. I think this is a very impressive presentation, and I think you are just like a very talented director, movie director. Thank you.
Thank you. I just like actually I saw the schedules, and actually in the same day that they have the anastomosis workshop from Professor Tanikawa today.
Okay.
So it's just like, oh my God, for Dr. Bin, I have to.
Okay,
Yeah.
maybe I will invite you for drawing something for us.
Yeah, we need some more bypass. We need some more bypass pictures.
Yeah.
Yeah, but I will for Dr. Bin, you just like, you know, my other like respects mentor. So maybe if I just like receive some of yours fighting or something, I always open and drawing for you.
Okay,
Very
great.
good. Great.
Yeah.
Okay, very good. Okay. Again, any comments or questions from the audience for Woralux?
I think this is a very effective, it's a kind of learning way. When you're drawing, you can remember, and you can teach in the memory of the procedure, and make it sure the correct position, and maybe this nerve, this vessel, which is upon another structures. This is a very effective way to learn. And also when you presented your drawings, and I think this is a kind of art. Yeah, you can present it as this. I always told my colleagues that our arts are just in the patient's head, but if you're drawing it, it's a kind of different story. Yeah.
Yeah,
Okay.
it's actually every surgeon is art. I mean, even when we design the surgical flap, it's art already. Yeah. So what I want to encourage that do not have to scare to do this type of things. And just like, for example, even today that I study anastomosis, I always like confused, like, oh, what should be inside in, inside out or something. So maybe I think two ways that it's important to encourage people to study is you have to do it by yourself. But if you cannot do it by yourself, you have to like drafting on something. Like, yeah.
Yeah.
So, yeah.
So it's very impressive, and you are so productive. Thank you, Takash.
Takashi,
Takash.
you want to
Yeah,
talk?
yeah,
You
yeah.
want to say something, Takashi?
Yeah, thank you. The nice illustration. I have no talents and very hard to write down my operative drawing. So it's very informative. So I want to study from scratch, sketching and some shadows. But it's very difficult. So I want to learn from you in the future. So I follow the Instagram. So I will study from scratch. Thank you.
Yeah,
Okay.
thank you very much.
Very good. Ahmad from Afghanistan. Do you want to say hello to Woralux? Are you there, Ahmad?
Thank you very much. Congratulations, it was a nice presentation and achievements, and we know it's a part of education is learning by drawing, and if we imagine a pathology or a structure, it would be a kind of way for success and how to approach for surgical and after surgical operation, and it's really very nice and excellent work. And I also have the habit to draw on the whiteboard for our students and the university, and also for our resident. I draw as well, but it's not so nice that Phusoongern drawing. It was very excellent. Thank you very much. And I suppose and propose that if we have also in the curriculum and for the residents drawing course as well, it would be very useful for imagination and also drawing. Thank you very much. It's very nice to see you, and thank you, Professor Bennett and Benzu, and also Phusoongern. Thank you very much. Also, that's Liu Zing. It was also the presentation very excellent and very useful for us. Thank you.
Okay, very good. Wan Li, are you still there?
Wan Li.
Wan Li?
Yeah, actually, yeah, your presentation make me remember that when I was a resident, my senior neurosurgeon always asked me to draw a picture after every surgery for the anatomic structure for the surgery and mark some important anatomy for the surgery. So that makes me quickly understand what happened during the surgery. Yeah, I think it's very important to join something by yourself. Yeah, just as being that we should invite you come to China to. I think we can organize maybe a special seminar and invite you as the teacher, right?
Thank you very much.
Very good. Mohammed, go ahead. I'm sorry. Go ahead.
That's very easy for you to travel. You're in Bangkok, right?
Yeah, I am actually I'm in Chiang Mai, but I came to workshop for the anastomosis. Yeah, in Bangkok.
Much more shorter.
Yeah, Chiang Mai is close
from-
to China. I have a lot of Chinese friends in Chiang Mai right now.
That's our flight. Yeah, wonderful. Yeah, definitely. We will invite you later this year.
Oh, thank you very much.
Very
And
good.
you are all welcome in Chiang Mai too. I think Chiang Mai and China are like neighbor.
I had visited Chiang Mai, right? Not Chiang Mai, but Chiang Mai, right? Another city.
Oh, Chiang
But-
Rai. It's in the more north. Yes. If you come, please contact me. Okay.
Okay.
Very good. Mohammed Helmi, are you still there? Mohammed, do you want to check in?
Yeah, hi, John.
Hi,
Yes,
welcome.
thank you so much. Great topics tonight. Actually, following my supervisor can show me, Professor Shubin can show me how a neurosurgeon can draw art in patient's head every day. But today also, Dr. Woralux show how a proof about the artist neurosurgeon. I really appreciate what she did, and I hope all the best for her.
Thank you, Mohammed. Okay, any more comments, questions before we close? Okay, very good. Okay, I'd like to thank Woralux and Ben and Juan Lee and all the participants for coming out. And I think you have a great future, Woralux.
Yes.
Yeah.
Definitely. And I think
Practice.
you just mentioned the AI. I think AI also have to need some trainers. Maybe Woralux should be the trainer for the AI.
Yeah, you're familiar with that, right, Woralux?
But
go ahead.
Yeah, but people nowadays that really excited things about AI, and they try to training more and more of them. Yeah, I think one day maybe. Yeah, I will not say that one day. I think that maybe even now they can do it. But for our fields like surgery, especially something it needs something like so precise. So in my opinion, it's still like, need to take time and have to take time to train it or something. But for the art itself, yes, they can create art that about the medicines, but we're not talking about a general art, like we just, okay, draw the liver or draw the brain. It's not about that, but for us, it's just like draw something, it's more precise and unique. It was I believe,
like
because sometimes I just
the experience of drawing, right, that you kind of imprint your mind more.
Yeah, or you can ask, maybe you can type some of the AI program that draw me the basilar tip aneurysms in which the neck is above the anterior gynoid process. Or something like that, I really want to know what it's gonna be like. But I mean, I think but okay, maybe it can create art. But for me, the art for me is not only for showing, but it's related to treatment and for the people life. It's not only art for just daily and you just see it and it's beautiful, but art for us, for the neurosurgeons, it's life. So some art, maybe they have some mistake and you just can't look over it. But for our art, it means that it has to be, that's why we need a mentor, we need the people to correct that. Even a single mistake, we cannot like skip it. We have to correct that because it can affect the treat. Maybe some people understanding. It's more important than just only art. This is that's what I think that it make our fields like unique. This is my understanding.
Great. That's a great way to end it, Woralux, and we'll continue to follow you in your career. And thank you everybody for coming, and we'll see you in 2 weeks.
Okay.
Yeah.
Thank you.
Bye-bye.
Bye-bye.